So before we start, let me give you briefly what the cardiac anatomy is. So your heart is in your chest, okay, and then there's 4 chambers. There's the right atrium is here, the right ventricle, left atrium, left ventricle, and your lung sits here like that. And there's 3 vessels. Basically the aorta. In, Before I talked about the aorta, blood goes into the right atrium from 2 vessels, superior vena cava, inferior vena cava, and blood goes into from the right atrium to the right ventricle, then go back into the lung, and here is where they add oxygen to it, and then it return back to the heart through the left atrium to the right ventricle, to the left ventricle, and then it goes back to the lungs, to the rest of the system, circulatory system. So from the left ventricle, it goes to the rest of the body. And this is the aorta. What we'll be talking about is what usually happens. The heart, this is the structure of the heart, and the 3 vessels that go to the rest of the body. There's a layer surrounding the heart. Okay, it's called pericardium. So this, and this is a sac. It's 2 layers. One on this side, the other one is on that side. So it's the green layer. Okay, so the first layer is the green layer on just right on top of the heart, and the other layer is this color. This is what we call the pericardium. In actual fact, there's 3 layers of the heart. Okay, there's the endocardium. Okay, this is the inside the heart, and then there's the muscular portion of it, which is the myocardium, and then the outside layer, pericardium. So the pericardium is 2. Okay, so and there's a space here. There's a small, tiny space. This space where there's small fluid there to lubricate the heart. It can move easily. So this is the pericardial space, and there's fluid, the small fluid there to lubricate the heart so they can move around without being stuck anywhere. So this is the pericardium. So that's the pericardium space, and this is the hole. So the green color and this color all together form the pericardium. And so what we'll be talking about, 2 of the pathologies we'll be talking about is between this space, and it's very important you pay attention to. And so even 3 of them, yeah, they're all related to this small area of the portion of the heart. So how does effusion happen? Well, cardiac effusion. So I'll draw back the heart again, and then I will show you the layers. So the first layer, assuming this is the first layer of the pericardium, just surrounding that area, and that's where the fluid is. And the second layer, maybe that. So these 2 layers is the pericardium, okay? So this is the 3 portion. So effusion happens if between those 2 spaces, there's a fluid that the fluid that is supposed to be there is more than what is expected. And so within this space, you have too much fluid surrounding the heart. The normal physiological amount. And for example, if the amount of fluid usually is maybe 50 ml, okay, I'm just giving you an example. Now it's 500 ml in that space. So you see, there's a problem. So that's what it means by effusion. There's so many things that can cause effusion. Okay, there's so many things. One of them is basically infection. So when you have infection and you develop bacterial infection will cause secretion of their content, and all the inflammation that ensued after infection will create what we call infection and fluid, and you develop effusion. It can be due to tumor. Okay, tumor cancer cells can also secrete fluid, and that can go into the space, and that become a problem. Okay, sometimes it may be trauma. Okay, so when trauma is, so that means there's blood going there. You have blood going into that space, and that is another problem that can present, that can create effusion. So there's so many things that can do that. These are the three areas that we already know, that infection from the inflammation, the tumor cells can secrete fluid. And then if you have trauma, that means you had a car accident, something injured, and there's a fluid going into that space, and that created the effusion. And as you can see, if there's a fluid around the heart, then the heart cannot function properly. And so what happens, the fluid can start to push on the left ventricle. Okay, it constricts the heart. It constricts it such that it doesn't do its function. So there is constricted effect of the fluid. When it does that, then the left ventricle cannot function. So blood going here will not be perfect. So there is less blood coming up. If blood is not going out into the system, then it will back up into the lung. So you may have some pulmonary symptoms. If blood is now cannot go out, the heart is all full of blood and is being squeezed. It can't do what it's supposed to do. You see, the heart, when it's is making a sound, when it's squeezed, is the squeezing of the heart. That's the pumping that give out sounds. So it will change the heart sound. So the heart sound will change. And then if the blood cannot be pumped, well, then the right side will hold on to the blood. So you have what we call congestion on the right side. And so that congestion will present like there will be increased pressure in these veins. So you have what we call JVD. So there will be JVD or CVP will increase. So this is what happens. There's more fluid on the right side because the heart is not pumping, it's being squeezed. It's being squeezed. And so you can have both lung symptoms and then right-sided heart failure symptoms. That's how you see cardiac effusion, depending on what you have. And so this is just briefly, and we're going to build on this. And so anything you can have infectious causing the wall of the pericardiums too thick, and then you squeeze the heart. That is the constrictive. So it can be constricting it, or it can be just the fluid that is outside that is causing the problem, or there's blood, acute blood in that space. And so when they say effusion, it can be anything, fluid into the pericardial space, and that will squeeze the heart. And the symptoms are always going to be the same. So let's use that pathophysiology to look at this problem. So cardiac tamponade is the same thing. The only problem is this is your heart and this is your pericardium. Okay, I'll use green. Pericardium is here surrounding the heart. Okay, and so we have 1, 2, 3. So this is our pericardium. There's a fluid in the pericardial space. This is what is surrounding the heart. The sac surrounding the heart has fluid in between it and the heart. And this fluid is usually blood. So now we have blood here. There is blood. the fluid. There is fusion. It's a kind of effusion, but that kind of effusion is blood surrounding your heart. And the difference is this is an acute. This is usually can happen acutely, and the most common is trauma. Okay, trauma. It can be not a chronic form, just from fluid, or maybe fluid from infection, effusion, that is infectious fluid can do that. But yeah, I'm focusing on trauma, and this can be blood, okay, or it can be just regular old infection that has built up. So this can also be infection, or it can just be cancer cells that is making fluid. So three things, all the things we cause that we said can give you effusion. Now this is tumor. So these three things, it can be blood, that's trauma, it can be infectious, or it can be just a tumor. They can let the fluid surrounding the heart too much, and then that will start giving you symptoms. It's no more just effusion. The effusion has developed into cardiac tamponade. And what do we mean by that? And that is the key, okay? Now the fluid is compressing really bad. You're becoming more symptomatic, and it can happen acutely. We have to do something about it. And so there's something we call big triad, and that is what you should know for cardiac tamponade. And I call them the 3Ds. They are the 3Ds. The first D is decrease blood pressure. So now the ventricle cannot pump. It's being squeezed, so blood cannot come out. So your blood pressure goes down. So decrease blood pressure. So decrease blood pressure. Okay. And then if the heart is squeezing, the heart sound comes out from heart squeezing. So if your heart is squeezing really fast, the sound is louder. If there's a moment when you squeeze, you hear different sound. And therefore, now that we're squeezing the heart, it can squeeze, it can, we're putting too much pressure on the heart, it can't give you any sound. And so the sound will be distant. It will be very far away. You can't hear it. So we call it distant heart sounds. So they have distant heart sound. The other way they can give you, if you see muffled, is muffled heart sound. Is the same thing, muffled heart sound. But to remember the 3Ds is decreased blood pressure, distant heart sound, and then the third one is distended neck vein. Neck vein. I told you, now the ventricle is being squeezed. So this is the left ventricle, this is the right ventricle. The ventricle is being squeezed, and so it can pump the blood, where the blood will go backward. It go to the lung. The blood now go to the lung, and then go back to the right ventricle, where the right ventricle receive blood from what? The superior vena cava through the right atrium and the inferior vena cava. And so this area will become congested. And so you have what we call distended neck vein. Distended neck vein is the same as JVD. So jugular vein distension, that's the superior vena cava that it receives its blood from the jugular vein. That's the vein, the big vein in your neck. And so you see in a JVD, increased JVD. The other way will be CVP, central venous pressure. And usually your central venous pressure is 2 to 8. So that means there's too much pressure outside in the venous system. And so this will be, their pressure will be greater than 8 with the CVP, if they give you a CVP, or if they give you a JVD. So these are the 3Ds: decreased blood pressure, distant heart sound, and distended neck vein. Those are classic for cardiac tamponade. But there's other symptoms that they will show. These are the three, but sometimes they will add more because you can think about it. Now, the heart cannot pump, less blood is coming, and then all the blood is on the left side. Well, your body will be in shock. So in order to compensate, so this is compensation symptoms, you're going to increase your heart rate. So increase heart rate. And so they will have tachycardia. So you increase heart rate to increase your cardiac output. Remember, I don't want to go too much. So cardiac output is stroke volume times heart rate. We can't do anything to stroke volume because the blood that is coming there is small. So it's being squeezed. So in order to increase your heart rate, you're going to increase your, in order to increase your cardiac output, you're going to increase your heart rate. So that's why the heart rate is very high. Now blood is building up in the, it can go into the left ventricle. So it will stay in the lungs and then go to the right. So they will start having pulmonary symptoms. And what is that? If there's too much blood in your lungs, well, you have dyspnea. Okay, dyspnea. They have dyspnea or tachypnea. So that's the symptoms. Those are the 5 symptoms that you have. The one thing they like to ask is, and it is a little bit confusing, but it's easy. Look at it. If you can pump blood out of the left ventricle, okay, and your most of the blood is in the lung, is in the venous system, your blood pressure will start to decrease. But how does it decrease? It's the systolic, because the heart cannot push the blood. So it's not pushing it too much. So it's the systolic blood pressure. So if this is your BP, usually you have systolic blood pressure and over the diastolic blood pressure. Well, the diastolic, there's a lot of blood in it now. Yeah, the venous, the diastolic blood will be a lot because the heart is not pumping blood out. So most of the blood is staying in the heart. Is the systolic blood pressure that decrease. And what happens is the systolic blood pressure will be close to the diastolic blood pressure. It will be close, but it's not equal. When they give you a blood pressure and systolic blood pressure is almost close to diastolic blood pressure, that's bad. That's what we call narrow pulse pressure. Pulse pressure. So these patients will have narrow pulse pressure. That's number 6. So narrow pulse pressure. And so that's what they have. The systolic blood pressure starts to be closer to the diastolic pressure. And the last one, I'm just giving you some of the things because in case they give you a SATA question and then you know only the basic, but this one you don't have to memorize. You can think about it. Like now I can pump the blood out. I have more diastolic pressure, but then my blood pressure start to decrease. What is going to decrease is the systolic, because the ventricle, as it pushes blood, is the systolic that goes up. And therefore, you have narrow pulse pressure. Now, what is going to happen is when they take breath, because they have too much blood in the lungs now, is backing up. When they take breath, as they take a breath, there will be exaggerated feeling of their blood pressure is decreasing. When you have them on a monitor, this may be another question they will ask you. There's a patient in the ICU, is on the monitor, and his blood pressure is 120/70. Whenever he takes breath, his blood pressure drops to 110. So any systolic blood pressure that decrease greater than 10 millimeter per mercury with inspiration is an indication of cardiac tamponade. And this is what we call pulses. So the pulse paradoxic. Paradosis. So pulses paradosis. basically is a paradoxical change in the blood pressure. It's a fancy word, but it's a paradoxical change in the blood pressure. When they take a deep breath, inspiration breath, the blood pressure drop by 10. Systolic will drop by 10. So let's recap. Tamponade signs is there is 3Ds. That's classic. This is big, or we can big triad, big BECK triad. That means 3. It's all, and they are the 3Ds: decreased blood pressure, decrease distance heart sound, and then distended neck vein. But then there is compensation, which is increase in heart rate, which is tachycardia, dyspnea. They will have narrow pulse pressure because systolic start to become closer to the diastolic pressure, and then they will have pulses parodoxical, which is the systolic blood pressure drop by 10 with inspiration. So this is all you need to know in terms of the presentation of cardiac tamponade. So how do you treat it? You know the problem, fix the problem. There is blood in the pericardial sac, then just remove the fluid. That's all. Removal of fluid. And what is that? Science, sometimes we don't, we describe things by its name. So the procedure means pericardiocentesis. You heard about thoracentesis, paracentesis. Centesis means removal of fluid. Where are you removing the fluid? From the pericardium sac. So that is pericardiocentesis. When you see it, don't worry about it. Don't be disturbed. It's a fancy word. All it means is I'm doing centesis, removal of the fluid in the pericardium. And so that's it. So that's emergency. This problem is, who do you see? I give you 4 patients with symptoms of pulses paradoxical, muffled heart sound, hypotension, distended neck vein. These are patients, you have to see this patient. It's a priority one. Cardiac tamponade is a priority. So know the symptoms. They like asking hypotension, muffled heart sound, or distant heart sound. To remember, it's the 3D. Decreased blood pressure, diastolic, getting closer to systolic, that's pulses paradoxical, wide, narrow pulse pressure, and distance heart sound, distended neck vein, tachycardia, tachypnea, pulses paradoxical. That's a cardiac tamponade. You need to see these patients. Once again, 4 patients they give you with symptoms of pericardial tamponade using the 3D, decreased blood pressure, distant heart sound, or they will use muffled heart sound, distended neck vein, or they can change it, put tachycardia, pulses paradoxical, narrow pulse pressure. They will give you blood pressure, and you have to figure out if it's a narrow pulse pressure. You need to see that patient. It's a priority patient. What would they confuse you this with? Well, pneumothorax. What is pneumothorax? So this is your trachea going to the bronchiole, okay? And your lungs are here. Of course, and your rib cage is around it. So this is your rib cage. And your ribs are here like that. They're protecting you from any trauma, okay? When you take a breath, it's supposed to go into trachea, go into your lung, go into the, just in the lung, doesn't come out, and then you breathe it out. And there's vessels here with the vessels that allow exchange of oxygen going to the blood and go to the heart and returning back. There shouldn't be, this space should be free of air. There shouldn't be any air molecules here. When you have air molecules here, so this is air, pneumo. Pneumo is air. When you have any air molecules here, we call it pneumothorax. So air in the chest. That's all it means. Pneumothorax, air in the chest. That's bad. Look at it. If there's air here, it will build up this space. Instead of staying in the lung, it will build up and it start to squeeze the lung. It squeeze the lung. So the lung will be squeezed like that. So this will be where the lung is. And so you can't take breath. So when you listen them here, you have decreased breath sound because the breath sound is coming from the lung expanding inside the lung itself, not outside. So they will have decreased breath sound. So this is what they can confuse you with. Unfortunately, if there's too much air, okay, if it build up, it continue to build up like the effusion, cardiac tamponade is too much effusion now pushing on the heart. Tension pneumothorax is too much air. I mean, it happening acutely. You have not taken them out. So now they're building up. Well, they're going to push on the lung and completely and collapse the lung. If they push on the lung, it pushes the mediastinum. Mediastinum means the trachea start to move, deviation, everything to move. The heart also move. Things start to move away from where they is. And then you start having symptoms based on that. Therefore, based on this pathophysiology understanding, you can tell that if you have tension pneumothorax, this is the right side, this is the left side. If this is the problem here, okay, I'm going to push everything towards the right. So there's deviation, trachea will deviate, okay, deviation of the trachea. Or they will tell you deviation of the mediastinum. That means anything in the chest will move away from where the air is because it's pushing away. If you listen to where the thorax is, the injury is on the left side, there will be decreased breath sound. Okay? But because you listen to a lot of air that is floating around, we call it hyperresonance. It's different. So you have hyperresonance. You're hearing just the sound of the air that is like basically making too much noise. But on the lung, they have decreased breath sound. Okay. And that is the difference. That's how they can trick you. Okay. So decreased breath sound of the affected side, but you may have hyperresonance on the other side. So pay attention on the answer choice. The trachea will move away. If the trachea is moving away, everything is being pushed. The heart is being pushed. Well, your blood pressure is going to decrease. It's the same thing. Blood pressure will decrease. So their blood pressure is going to decrease. So BP, decrease blood pressure. And all the blood, because the heart is being squeezed, the same thing, it can push the blood out. So blood will stay in the venous system. The blood will start to stay in the venous system. And that is the problem. This is why it is a little bit confusing. They will have JVD because blood stay in the heart is being squeezed by the lung now. It's known because there's blood in the pericardium. You have this air and squeezing, pushing the mediastinum. So if your heart is here, you start to move. And so it gets squeezed. So it can't do its function. So they may have JVD because there's a decrease in venous return. Okay. And that is also expected. So when you're looking at it, it looks the same as cardiac tamponade, except, the heart sound doesn't change. So your heart sound, there's nothing wrong with it. And then there's a breath sound. You see, there's breath sound here in tension pneumothorax. Change in tension pneumothorax, in change in breath sound in a pneumothorax compared to cardiac tamponade. There's no breath sound changes at all. So that's how you can distinguish between them, tension pneumothorax and cardiac tamponade. Nothing wrong with your breath sound with cardiac tamponade except tension pneumothorax. So how do you treat it? You know the problem, you just fix it. We got to remove all the air particles out. And so we do what we call needle decompression. Needle decompression. So you take an 18 gauge, usually 14 gauge. I don't think they will ask you too much, but a 14 gauge, 14 and between 14 and 16 gauge needle, big needle, into the second intercostal space at the mid-clavicular line, or fourth or fifth intercostal space. So fourth and fifth intercostal space at the anterior axillary line. So one is an MCL, the other one is fourth and fifth AAL. So second intercostal space, mid-clavicular line, or fourth to fifth intercostal space, anterior axillary line. And you will see the rush of air will come out and the lung will span and the patient will be fine. This is another priority patient. These two, cardiac tamponade and tension pneumothorax, if they give you to you, who do you see first? Boom, those two of them, you need to pick them, no matter what other choices is. I don't care. The other ones is not a priority compared to this. If you listen to my bishop, this is the airway problem. Patient is dying. Immediate chest decompression with the 14 gauge needle at the second intercostal space, mid-clavicular line, or the fourth and fifth intercostal space, anterior axillary line. And this will help them feel much better. So that's the treatment for tension pneumothorax. Now, the same theme we've been talking about. This is their heart. Okay. And then the pericardium is here. There's two layers. And there's another layer. So what happened in the pericarditis? As you can see the name, itis is inflammation, right? So there's itis is inflammation, some form of inflammation causing the pericardium to get into trouble, okay? To get into trouble. So something is affecting it. And then you make the pericardium really thick. If there's infection, the pericardium constrict. So you have something we call constrictive pericarditis. Now that's what we have. The inflammation, the wall of the pericardium is so thickened, it's now pushing on the heart. It's pushing on the heart, it's squeezing, it's not allowing it's like you wearing they put a big jacket on you, it's so heavy, you can't even run, you can't even do anything. The same thing, the heart now has a jacket on itself, it's cold, it has a jacket and it's squeezing the heart cannot expand because of that. So it's a constrictive effect. This can happen from viral infection, and I know you've heard it before, some patient has cardiac problem from COVID. This is one of them. One of the side effects of COVID is constrictive pericarditis. It causes pericarditis, inflammation of the pericardial wall. And viral infection is almost number one. Sometimes if you have TB infection can do that. It can cause pericarditis. Or if you have cancer, so neoplasm, like tumor. Autoimmune diseases, like systemic lupus, all these autoimmune diseases, they can deposit their complex. That means the autoimmune complex, your body antibody and the usual complex on the wall of the pericardium, and they form pericarditis, so autoimmune. And of course, idiopathic. Sometimes we don't know what is causing the problem, but viral infection is number one. And the way they do the same thing. So the symptoms you don't have to like worry too much. It's the same thing. Something is constricting my heart. Well, if it's not fluid and it's the thing is constricting my heart, it's going to do the same symptoms. This infection, this pericardial wall that is thickened, okay, this is thickened, is going to do the same thing. It's going to do the same thing as if there's fluid there. So the symptoms of constrictive pericarditis will almost be the same as if you're having effusion, okay? Except there's specific, because it's an inflammation, you will see things. They may have symptoms that look like pericarditis, pericardial tamponade, but there's specific in your test. You have to be able to distinguish them that this problem, this cardiac problem, is being caused by just not the fluid in the space, but the pericardium is in trouble. Okay, because it's an infection, what do you think? Well, they will have fever. And then because the pericardium wall is now thickened and it's inflammation, they will have pain. When do they get pain? Your heart and your lung are close together. So when they take a deep breath during inspiration, as they take a deep breath, the pericardium, the two walls rub against each other. I told you there's two layers. They rub against each other. And because of the infection and inflammation, there's friction. There's two things like gravels ripping each other. Usually they are very smooth and they slide among each other. Now they can't slide because of the infection. So when a patient takes deep breath, they have pain. But when do they have pain? During inspiration or when they cough, as your lung forcefully pushes out. And then because of the friction, you hear something we call friction rub. So that's the key word, classic word, friction rub of pericardium. So they have friction rub. This is the friction rub. Is the sound. Is there's a high pitched sound as the two layers rub each other, and it's very painful. So that's what the patient complain about. Because they are having chest pain, so this is chest pain. So fever, chest pain, when they have inspiration or when they cough, and you hear a sound called friction rub. Because of the chest pain, people think they have a heart attack. But when you get an EKG, you see the EKG here, almost you see ST elevation. Oh, there's ST elevation everywhere. When somebody have a heart attack or MI, there's few leads that have ST elevation. In this one, you have something we call diffuse. So diffuse everywhere. Diffuse ST elevation. This is classic for pericarditis. So that one, diffuse ST elevation, friction rub, chest pain, when inspiration, and sometimes they have fever. And you see, you can deduce some of the symptoms and the finding based on your understanding of the disease process. So that's the pathophysiology. So they get diffuse ST elevation. So when they give you EKG and you see a bunch of ST elevation, these are ST elevation, this is a sign that this is pericarditis, it's not heart attack. Then that's how you can distinguish between them. So we already know this pathophysiology. So what do you think you're going to treat them? Well, when they have chest pain, when they take a deep breath, in order to open their chest, like pancreatitis, when patients have pancreatitis or any abdominal infection that is making you sick, or what we call peritonitis, in order to release pressure off your muscle, patients stay in the fetal position. They bring their knee to their chest. So they open their abdominal cavity. The same thing, these people, let them open the chest cavity. Open chest cavity. Your chest is not that too flexible. to open it like your abdomen. So what they will do is they lean forward. So lean forward. They will tell you, they will figure out, this patient will figure out. They said, when I have chest pain, when I lean forward like that and then take a deep breath, it feels much better. So the question they will ask, the typical NCLEX question or board question would be, hey, a patient with chest pain with the friction rub, which get better when they lean forward. Your diagnosis is acute pericarditis. So that's how they do that. Then is an infection. You treat it with antibiotic, NSAID. It's inflammation. So NSAID help with the inflammation. So you can give it some NSAIDs. The common NSAIDs that they use is colchicine. You've seen it in gout. So this is the medication you use it for gout. So it's a gout medication. It's the same in etiology. Somebody have got gout, is an inflammation in the joint, the big toe. So you give them colchicine. The same thing, they have inflammation of the cardiac pericardium. You give them colchicine to help with that. And usually that take care of it. Whatever the etiology, most of the time it take care of it. There's some patients, and then you can use steroid if it's autoimmune. Okay, so if it's autoimmune, you can give them steroid, and then steroid will take care of it. If that none of them doesn't help, they have to go and scrape the pericardium. So it's like removing the pericardium. So pericardiodectomy, basically they will remove the pericardium to scrape it. This, I want you to pay attention. So some people cannot take NSAID because of certain problems. So they have the first line, they may have to go to steroid right away. But first line therapy, number one therapy is NSAID and is colchicine. Patients who cannot take NSAID right away because of the medical problem, well, they have to start with steroid. And these are specific patients. It's not somebody who has reflux or also you can give them something, you change other therapy, you can protect their stomach with other medication. But this one is like if they have renal failure. So if you have kidney issue really bad, where NSAID will worsen it, you don't want that. And a pregnant lady. So if they're pregnant, and it's more than 20 weeks. If you look my PEDS lecture, and I have a video on cardiac defect, 20 weeks, your PDA, something we call patent ductal arteriosus. So ductal arteriosus usually is kept open, by prostaglandins, okay? If you give them NSAIDs, NSAIDs will close the ductus arteriosus. They need the ductal arteriosus to exchange. Their lung is not mature, so blood doesn't go to the lung for oxygen to be added to that. So the blood is shunted from the pulmonary artery to the aorta, and they go into the system and help with them. Basically that's how they get their oxygenated blood. So ductus arteriosus remain open. When they get born, as soon as you get born, your lung developed, and when you take your first breath, the ductus arteriosus closes. Okay, the ductus arteriosus closes. If it doesn't close, it becomes PDA, patent ductus arteriosus. So you avoid NSAIDs in pregnant lady who is 20 weeks, because then when you give it to them, the ductus arteriosus prematurely closes and the kids cannot get oxygenated blood. If they are born and the ductus arteriosus persists, that is patent ductus arteriosus, in order to close it, then you give them the NSAID. The NSAID you give them, this I digress a little bit, indomethacin. So you see how everything is so interconnected with signs. Yeah. So for pregnant lady, don't give them NSAID because if they are more than 20 weeks, it will close the ductus arteriosus. It become premature, and then they will have problem. So that is everything about pericarditis. So we'll recap with a question. It's a SATA question. I told you, I always like SATA. I don't want to be afraid of it. So, which of the following is consistent with the diagnosis? So, a client presented with the emergency room and was admitted with the presumptive diagnosis of cardiac. So, he has cardiac tamponade. So, which one is consistent with that? So, we know the pathophysiology involved. What is cardiac tamponade? So, we got to look at our answers. CVP of 15. I told you normal CVP is 2 to 8. If it's 15, that means increased CVP. Increased CVP is the same as JVD. And cardiac tamponade has increase in systemic vascular pressure is very high. And so there's decreased left ventricular function, and therefore they will have this problem. And so this is the right answer. This is expected. Their blood pressure is 100/90. Look at it carefully. Systolic blood pressure is almost close to diastolic blood pressure. That means they have narrow pulse pressure. This is bad. And that's what you see in tamponade because the left ventricle cannot pump, so blood stay in the heart, and the diastolic pressure is higher, and the systolic pressure drop, and they get closer to each other. So this is also finding. Even though it look okay, I mean, that's narrow pulse pressure. You have to calculate. This is the tricky one. Hyperresonance on the left side, where hyperresonance is tension pneumothorax. You see, that's how they can confuse you. Decreased breath sound, the same thing. This is tension pneumothorax. There's no change in your breath sound in cardiac tamponade. Description of pericardiocentesis. This is the treatment for cardiac tamponade. Friction rub. The pericardium, there's fluid in the pericardium, but the pericardium is still smooth. So the pericardium can still slide on each other. They don't slide on each other if there's a pericarditis, the actual inflammation of the pericardium. And so this is acute pericarditis. So this is wrong. Prescription for colchicine. This is the treatment for pericarditis. Diffuse ST elevation in all leads. Treatment for pericarditis. Distant heart sound. I give you a clue, the 3D of cardiac tamponade, which is decreased blood pressure, decreased heart sound, which is the same as muffled heart sound, and then distended neck vein. Therefore, this is that. So this is all you need to know about those two information. I've tried to make it easy for you as much as possible. Before we go, I want to say something. I don't think they may ask that, but just for your, I need a space. I need to clean. For in case they give it to you, you can have something we've called pericardial decompression syndrome. You don't know what they can ask you because of the next generation questions. Some of them are application, clinical thinking. If the patient is the heart here, okay, the right atrium, right ventricle, left atrium, left ventricle, and there's fluid here, okay, around the heart. Is squeezing it from working, and the patient is in he has pericardial effusion, okay? So the heart doesn't work well. All the symptoms we've talked about, pericardial effusion, the ventricle cannot pump well, and so their blood pressure is very close. They have muffled heart sound. They have shortness of breath, and all those things happening because of the pleural effusion. If you remove the fluid, I'm not talking about cardiac tamponade. If you remove the fluid for effusion, so this is a patient who has effusion, chronic effusion. If it's a chronic effusion, they usually don't have symptoms of the cardiac tamponade. Cardiac tamponade, it just happened right away. There's too much, it's squeezing it. So if you have chronic effusion without symptoms of cardiac tamponade, when they remove the fluid, look at what happened. If I remove the fluid, all the blood in the right ventricle, just basically, is trying to get to the superior vena cava. Is trying to get to the right ventricle. It couldn't. All the blood would just rush to the right ventricle, right? If you rush to the right ventricle, what happened? It pushes back on the left ventricle. So its opposite was what was happening when they are in trouble. Now there's too much blood in the right ventricle and the right atrium because the superior vena cava, which is here, and the inferior vena cava now can dump their fluid into the right atrium and right ventricle, and they get bigger and they push on the left ventricle now. The left ventricle cannot pump anymore, and so blood goes to the lungs. Your lung is in trouble, and so they develop left heart failure. So this is a left heart failure. And what are the major symptoms of left heart failure? Pulmonary congestion. So this is just for your understanding that if they can give you this pericardial decompression and syndrome, you've treated their effusion, you remove the fluid, and then boom, they started having left heart failure. It's because now all the blood rushed to the right ventricle, and the left side, the right ventricle is pushing on the left ventricle, and they go in left heart failure. And the common symptoms of left heart failure is pulmonary symptoms, and that is something to add to that. Once again, thank you for listening. If you like this, check my website on YouTube and subscribe to that. I hope you learned something out of this. Good luck in your exams and keep charging.